Uh, Good evening, everyone. I welcome all of you to this 251 of a Gyan Pravah web series. This is a brainchild of our Foxy president, Dr. Sunita Tandulwadkar. As all of you know, this is entirely a effort and one-man show of her, and she make us that what we are today. And she is the person who always taught us that you required a persistence and prayer. Like anything you take over, it should be a every time you should be a persistent enough to make it happen. And now, being it is a 251 episode, we are having the days of 350, and in a few months madam will be completing that task, and she make as a chairperson of the Foxy Family Welfare Committee, she given us a task to make that every time when we come across the different fraternity, maybe it is from the political leaders or it may be from researchers, it will be a scientist, it will be from a different fields. And what makes us a special, that she given us a stage that we can interact with the such a nice and such a knowledgeable person from the world. So welcome you all. Today we have another guest from the different country, and I must say he has different things to tell to all of us. That when we talking about infertility, we always talk about the couple. We usually investigate the female infertility for a longer time, but we tend to forget that is a male factor is equivalent to investigate. And he is none other than Dr. Marlon Martinez. He is from Philippines, and we are going to talk to him in a minute or so. Prior to that, I request Dr. Ashwini madam. She is a joint secretary of the Foxy, so request her to say a few words about the webinar.
Hi, good evening, everybody. A warm welcome to Dr. Marlan. He's really a very, very good friend of us and he's visited India multiple times. So I must say he's as much a member of Indian society as much as he's from Philippines. And who better than Marlan to actually speak on male infertility, the past, present, and the future, because he's worked extensively in this field surgically as well. And as rightly said, the time has now come that we openly speak about this, probably what they call as sperm, the silent half. Now it's time to make some noise, probably, about these problems. And a very warm welcome, Marlon, to this podcast series, which is being hosted by Foxy under the leadership of Dr. Sunita Tandulwadkar, madam, every day from 8 to 9 p.m., where these 30 chairpersons interview people from different fields every day. So it's a very enriching and a learning experience for all of us here. So it's really wonderful to have you today. And as you all know, that Sunita madam is busy with FIGO conference happening at Cape Town. So hence I have joined. But she makes it a point to join all the podcasts. And we have been working tirelessly here on preconception care Sampurna, which is a brainchild Foxy project for the year. So which also speaks about this fertility part and the importance in preconception. So I think I'll join in from the viewers link and enjoy this wonderful talk on male infertility. Thank you so much, Marlon, for joining. All the best, Dr. Ashish.
Thank you. Thank you, Dr. Ashwini. It's a pleasure talking to you and the blessings from you for this webinar. So, friends and colleagues, we are going to have, it is my privilege and pride to introduce to all of you our guest, Dr. Marlon. He is from Philippines. He has done the diplomate from the Philippine Board of Urology. He is the fellow of Philippine Urological Association. He is a fellow of Philippine College of Surgeons. He is a fellow of Academic of Medicines of Philippines, member of Philippine Society for Fertility Preservation. He is an active member of Global Andrology Forum. He is active member of American Society ASRM. He is also an active member in Aspire, and a special interest he's having in a relation to the andrology and infertility. To say a few publications, and he has many accolades to his credit. He has done a publication in male infertility, like a clean filter syndrome, medical management of male infertility, then antioxidants and the sperm DNA damage, epidemiology and genetic disorders in male infertility, in the infertility male patients with the genetic cause, and many more. So, welcome, Dr. Marlon, for this web series that the Foxy is going to have for last 365 days throughout the year. So from the Foxy side and from the Family Welfare Committee, we welcome you for this August gathering.
Hi, Dr. Kalia. Thank you so much for this great opportunity, for this invitation to be part of your podcast series. It's really truly a great opportunity to be part of this activity.
So, Dr. Malan, when we talk, because in India we know that male factor and female factor infertility plays an equivalent role as far as the evaluation is considered. When we talking about the past, present, and the future of male infertility, so I just wanted to ask you because I gone through your CV. It is an extensive CV to read. Can I ask you one thing? What is the particular thing when you're doing your graduation and post graduation? What makes that you turn interest into andrology?
During training, when I was a first year urology resident, one of my mentors, one of our consultants, asked me to present the newest semen analysis manual of the WHO that
Yeah.
was 2010. So during that time, I was assigned to give a lecture in a conference. So I studied the whole manual. So somehow it ignited the interest to pursue specialization about male infertility.
Okay. So once you are venture into this field of andrology, because all of us knows being a gynecologist, we always be, having the crowd of the females around us. But that pure, like a poor guy, when come down to the consulting, we never asked much more questions. To all our gynecologists, this is the association of 46,000 gynecologists across the India. They are watching you live. So what are the things like how compassionate you should be when you're talking to the male partner, because there are certain issues that they cannot be revealed to the female gynecologist. So how in a practice you should evolve as far as the male infertility practice is considered?
So we should know that male factor infertility can be solely responsible in about 20% of the time, and it can be contributory in another 30 to 40%. So meaning more than 50% can be due to male factor infertility. And it's very important for couples who fail to achieve clinical pregnancy after 1 year of regular unprotected sexual intercourse to undergo evaluation. And there should be a concurrent evaluation, meaning the male patient should be examined by a urologist. The female partner should be examined by a gynecologist. So just like how we evaluate any particular disease, we start with history taking. So this
Mm,
includes
mm,
family history, medical history, gonadotropin exposure, previous surgeries, and past medications. So these are important that might affect the fertility potential. And after that, we proceed with physical examination, a thorough physical
mm,
examination.
mm, mm.
So probably in this examination, we focus on the genitalia. We
Yeah.
focus on the size and consistency of the testis because somehow the testis is mainly composed of seminiferous tubules, which is responsible for production of the sperm and production of testosterone. So meaning if you have a small testis, most likely this patient will
Mm,
suffer
mm,
from
mm,
testicular failure. So we also examine secondary sexual characteristic like the presence of gynecomastia, the presence or absence of hair or pubic hair. We also examine epididymis, the presence or absence of the vas deferens.
mm.
We also do rectal exam if indicated.
Yeah, so Dr. Marlin, as you rightly said, that in 2010, the WHO comes with their particular manual of the sperm analysis and normal spermogram. It has been changed. So, what do you think that why the WHO changed the normal parameters from certain parameters to the 2000? Now it is coming up in a different way. What is the reason of changing the parameters by the WHO?
Aki, they in the recent manual of semen analysis by the WHO, they added like additional studies two from European countries, one from Africa, two from Asia. So they added this somehow this population to increase the number of patients. But I think since semen analysis is still the cornerstone in the initial evaluation of the infertile man, the problem is it still cannot distinguish between a fertile or infertile man. So there's still some weaknesses and some threats with regard to this semen analysis. And even though it is updated, the 2021 manual for semen analysis, it's still some underrepresentation from fertile men in certain areas, in geographic regions. It lacked the reference limit. It somehow, although some of the tests, like one of the controversial topic about male infertility is the use sperm DNA fragmentation, although
Yeah.
they is now included in the semen analysis manual, but it's still lack in the education. And one of the tests also is the oxidative stress testing, the reactive oxygen species,
Yeah.
but still
ROS.
considered as a research or is an advanced test. Not these are not part of the routine examination, as well as the sperm DNA fragmentation.
Yeah, so Dr. Marlan, when we're talking about the differences in geographical area, so are there is a notifiable regional differences in relation to the cause, diagnosis, and management of the male infertility in a different continents? Because when you're
Um,
talking about the global scenario, so do you think that that is something that we should be taken into account?
Yeah, because somehow geographical location, somehow we have different etiologies of male infertility. For example, in our region, in our country, the Philippines, some of the genetic diseases are not present, like the cystic fibrosis causing
Hmm.
obstructive azoospermia. Those patients, like in the developed countries, like the US, for instance, those patients with obstructive azoospermia, the most common cause would be vasectomy. European
Oh,
countries, American, US, the most common cause of obstructive azoospermia is vasectomy. But in the developing countries like the Philippines, it's due to infection. Mostly they have
oh.
history of sexually transmitted infection. So somehow these factors, the etiologies, can vary based on geographical locations. And the somehow the biggest determinant of male infertility care can be also due to the system and the budget. For example, those
Yeah.
developing countries, unlike the developed countries, they have these advanced tests. They have a wealthier center, so they have the availability. They have the luxury of requesting all the genetic testing, all the sperm DNA fragmentation, reactive oxygen species. But still, even though we lack those advanced tests, we should have our own standardization, so quality control, so we can offer good quality care for this set of patients.
Yeah, so Dr. Malan, when we're talking about geographical there is a diversity as compared to the European countries, Asian countries. So what is the youth thinking of now? The younger generations are there are the bad habits, or you can say smoking is rampant, or maybe alcoholism. So how that things is going to affect the global fertility rate?
Okay, there's let's say study by Levin and colleague. They are fond of studying the decline about sperm count. And just recently, I believe, just 2023, they released this meta-analysis composed of more than 200 studies, like semen analysis from 1970s to 2018. And that semen analysis showed that there was a decline in the sperm concentration, like probably 50% from
Hmm. Yeah.
1973 to 2018. And the total sperm count, there's a decline of about 62%. So they attributed these to several factors, like lifestyle habit, like smoking, um, drinking alcohol, poor dietary patterns, endocrine disruptors, all these pollutions, these are possible etiologies to the deterioration of their reproductive potential.
So, if we are talking about is there is a something that is really going to harm our health, do you think the changing awareness, because in many societies I travel also across, the infertility is traditionally been taken into a woman's issue. So, how has the awareness and acceptance in the male infertility is changed worldwide? What is your perspectives on that? That how the things should be moved, and as a consultant, what we should be taken into account?
Yes, for many, many years, infertility was considered a female partner problem because male reproductive health was seen as a symbol of like strength, masculinity. And if a man was told that you are the cause of the infertility problem, it's like a threat to their masculinity. It's like a taboo. We don't want to talk about this. And in the past, we don't have a proper diagnostic tools to somehow evaluate this infertile man. But since the discovery of the sperm in 1600, now we have the semen analysis, we have the publication from the WHO. Somehow this underdiagnosed, this misunderstood, this neglected factor about male infertility has been really revolutionized, meaning we have now somehow awareness about male infertility as a factor in their infertility problem. There are many young colleagues who are training and specializing
Hmm.
about male infertility. Somehow this will extend
Excellent.
our awareness about that it's not all about female factor, it's also about male factor infertility. Just like I mentioned earlier, more than 50% can be due to male factor
Hmm, hmm,
infertility.
hmm.
And this awareness somehow will increase or improve the evaluation. Hopefully, this will improve the management, and hopefully, this will improve the treatment for this set of patients. Aside from, because I think yes, the development of the IVF and ICSI somehow revolutionized the treatment for this set of patients with infertility. But the problem is somehow on the drawback, or one of the effect of that is that some uh, does not evaluate the male patient anymore because they know that by this assisted reproduction, it can proceed with pregnancy even without the evaluation of the male partner.
Hmm. So, when you're talking about the technical advances and technical things that we definitely know, there is a ICSI, there is a IMSI, now DNA fragmentation testing, genomic profiles. This has revolutionized the management of infertility. So, do you think how we should proceed? So, we should proceed from the basic semen analysis, then to some test, then to go to the different testing. So, how you looking at, and are really these tests are going to have impact on the treatment?
Yes. First, I can tell about the how we evaluate first this infertility. So, uh, as for your history takings and your physical examination, you proceed with semen analysis, and it depends on the result of the semen analysis whether you request for hormones, whether you
Mm.
request for genetic testing, or whether you request for this radiographic imaging if indicated, and the addition of the some tests, some advanced tests like the reactive oxygen species for oxidative stress, sperm DNA fragmentation testing, and some genetic testing. Some are advanced genetic testing that I believe we don't have in our place in the Philippines. I believe still these are very useful tools in the diagnosis of this infertile man. But the problem is, despite we have this advancement in the diagnostic tool, there's still patients who still remain infertile. So meaning many are still undiscovered that we need to discover. There are many things that we need to study in the future so we can offer these patients the best treatment options, the best diagnostic tool.
Okay, so now we know that the best diagnostic tools will be going to evaluate the male factor infertility. But do you think the lifestyle changes and the environmental factors, stress, pollution, and digital devices exposure contribute to the decline in the male infertility across the globe?
Definitely, it's one of the major factors. Exposure to endocrine disruptors like the industrial solvents, the lubricants, the plastic, the pesticides. I mentioned earlier bad habits, smoking, uh, sedentary lives, eating like American diet, like you want
Mhm.
the steaks, you want burger, you
Yeah.
fry deep fried food. These all can cause negative effect or detrimental effect to the your fertility potential. So all these factors should be considered especially in the evaluation and treatment of these infertile men. But I always tell my patients, what is good for your heart is good for your sperm. So meaning have a healthy lifestyle,
Yeah,
you exercise, have enough sleep, don't
true.
stress too much. So most likely this will help you in pursuing to be a father and pursuing to have your own biological children.
Yeah. So again, coming out to the clinical question. So I'm like when we practiced in India, we always do with the first is a semen analysis. After, of course, the history taking and everything has been done. Then we'll go to the if there is a severe OATS, that is a asthenosteatozoospermia. So in some of the patients, we talked about the if the gonads are normal, we going to have the hormonal testing. But do you think the genetic screening will has a equivalent role to play?
Um, Genetic testing, if we follow the guidelines from the American Urological Association, ASRM, from the European guidelines, it's recommended if you have a sperm concentration 5 million to 10 million per ml. So meaning if you have a severely low
Severe OHs, yeah.
yes, severely low sperm concentration. And usually, if we follow, we request for karyotyping standard. We request for Y chromosome microdeletion. And this might help patients to determine those with testicular failure. And there are some patients, for example, those azoospermic men without with the absence of the vas deferens, usually request for CFTR gene mutation
Mm.
testing.
Yeah.
So
Yeah.
hopefully this will help in the the counseling with these patients, and some this genetic testing is might help, but like for example, the Y chromosome microdeletion, having a complete ACFA, ACFB microdeletions, these are not good candidates for sperm retrieval because studies have
Mm.
shown that we cannot retrieve sperm from this set of patients. So definitely these genetic testing are very helpful, but sometimes majority still have negative results, meaning they're still normal despite
Mm.
them having infertile.
Yeah. So coming down to the another question is a psychological awareness as a or dimensions to this problem. How do cultural benefits and beliefs, for that matter, and masculinity norms impacts men's willingness to undergo the fertility evaluation and the treatment? Because always we know, in my opinion at least, in India, they said that everything has to done with the female first, and then if there is a problem, I will check my sperm later. So this is the like a psychological dimensions in India. So how you look at the global level? Is the same or
So
is the changing now?
I think it develops somehow, especially during the pandemic, wherein even if they don't want, because some of the patients they avoid clinic visit because of the TUVU. So since we have, but the problem is when I noticed that during teleconsultation, most of the patient I talked to were the female partner. Probably 95% were still the female partner. But as I mentioned earlier, that infertility, about 50% of them is due to male factor. So we cannot
Mm.
take away from that scenario that male factor can be the cause of their infertility problem. So increase awareness. For example, here we have webinar, we have already our social media. We
Mm.
can post
Mm.
about the male infertility problem, that this somehow increase the awareness that it's not only a female partner problem, it's a partner of the couple. So meaning it's both male and female partners should be evaluated. How the female partner are evaluated, the male partner should be evaluated thoroughly as well. So this might help these men, because I mentioned earlier that they don't want to talk about infertility problems because it can be somehow it's like a threat to their masculinity. It's like a
Yeah.
sign of weakness. It's a sign of failure for them, but it's not the case. There is some problem with infertility that we can treat medically. Some can be treated with surgery. Some can be treated with assisted reproduction. It's not the end of the world if you cannot have your own biological children. If you seek consult, might be we can solve your problem. You can have your own biological children. You can be a father if you have this proper
Have.
concept evaluation.
So, what is your take on stem cell therapy or maybe the PRP, testicular PRP, as far as this low sperm count consider, or maybe some of the time they come up with the literature in their hand that saying that even if I'm having a very, very low sperm, but this is the ray of hope. So, what is your take on that, Dr.
I think
Marlon?
at this it's early to say the efficacy of the stem cell, but I see its use in patients with non-obstructive azoospermia with failed sperm retrieval, failed microtese. In fact, I believe that one of your, that Dr. Ranjit Rosam is doing a trial now about those
Yeah.
patients with failed microtese in the first sperm retrieval that they're doing stem cell therapy. They injecting exosomes on the testis, but they are
Yeah.
still on their and their
Lipase.
study though. So but he said that it's a promising result. So hopefully in the future they can have the result of this study, and hopefully this can help our patients, particularly in men with non-obstructive azoospermia with failed microtese.
Yeah. So, Dr. Malun, when we talk about the younger generations and they're facing the problems in, clinician facing the problems in a day-to-day practice in diagnosing and treating the male factor effectively, do you think that the present scenario is like that? Because this is the podcast is going to have to those who are practicing in remote areas in India. So majority of them maybe not experienced, maybe new things to them about this field. So, do you think that effectiveness of the clinicians and facing some problems related to the diagnosis as well as the treatment of the infertility is considered?
That's what I'm telling earlier, that some places are not well equipped with this evaluation tools. So somehow they are deprived with the proper assessment, and some of the centers don't have the experience or specialists with regards to infertility. So somehow this may deprive them the proper evaluation and proper treatment for this set of patients.
So, if you are talking about the future, nowadays everything is related to AI, everything is related to virtual, and then there is a something called as I personally know nanobots taking into the if the sperm is not motile, you can have that thing to be used. So, what do you think of the future as far as the treatment of the male infertility is considered?
We all always hear the word artificial intelligence, so the AI. So its
Yeah.
first application to male reproductive health was seen as early as 2010. But with the introduction of the artificial intelligence, its use in male infertility evaluation and treatment, somehow it's have its role in this set of patients, like use of AI for like home semen analysis. We have now
Yeah, yeah,
the
I
use
know.
your cell phone. It's through AI. Embryo selection for IVF. It can be also done. Prediction of semen quality. Prediction of azoospermic men necessitating genetic workup. Sperm detection. Uh, Detection of rare sperm. It can be used with the AI as well. So AI still can revolutionize the evaluation and treatment of these infertile men. But I think it's a long, long way to go. We need a lot of studies about this. But this is a promising results for us. It will be a great help for this set of patients who wants to be a father.
Okay, any new things as far as the treatment modality is considered apart from stem cells, what we discussed?
Okay. I think one of the, because we have a lot of semen animal studies about spermatogonial stem cell based restoration,
Mhm.
particularly, for example, for patients who are prepubertal boys. We all know that these prepubertal boys are there's a quiescent period wherein they have a gonadal development, but without the production of the sperm. So
Mm.
animal studies have shown, like the Grady, the from animal studies, they were able to produce a from a spermatogonial stem cell, but we still have or we still lacking the human study resulting to live birth. So I think in the future, hopefully, this will result to a good outcome using human spermatogonial stem cell.
Okay, so when we're talking about the new modality of the treatment, let me ask you, because you are the leader in andrology and andrological forum. So when you are dealing with the patients and dealing with the different societies or the organization, ASRM, maybe it's a andrology forum, where you may be discussing about the problems related to the clinician, related to the world, related to the decline in the sperm count. So, what message that you should be going to give it to the young scientists, young clinicians, or maybe like a couple, or maybe the future for the male reproductive health and importance of the male fertility research? Because I think in India, we have more patients, but our research is not that much developed yet.
Okay, the evaluation and treatment of male infertility is a multidisciplinary approach. It's not only based on the success is not only based on urologists, it's not only based on IVF specialists, embryologists, geneticists, or technician. It's a multidisciplinary approach. I believe Dr. Ashok Agarwal, Dr. Rupin Shah, they
Yeah.
created this group. This is the Global Android Forum. I don't know if you're familiar with that, the GAF. This is an international online community dedicated to advancing research and clinical practice in male reproductive and sexual health. So this was established during the height of the pandemic in
Oh,
2020,
yeah.
officially launched in December 2021. This brings together a voluntary global network of these specialists. They create a lot of studies, symposium, master class. Hopefully, this will increase awareness not only for the patient but for the clinicians.
Yeah.
They can offer the better service for these patients. Hopefully, this will improve the male health of these patients, and this will improve the totality of the practice of male infertility.
Yeah, so Dr. Marlin, because we are now like talking for more than a half an hour, I will not going to take your much time, but I really wish to ask your two personal questions. How you venture? I understand that your professor is asked you to read the WHO manual and coming down, and that ignites your research into the andrology forum. But when you are practicing your andrology, do you think that the certain things are yet to be evaluated or yet to be concerned about the male factors? Because our Asians has a different community practices. The like when I said community practices may related to the certain religion beliefs. So how as a clinician we can able to take care of that? Because if the religion is because if I'm coming from the world where the male factor dominance or male masculinity is much more taken into a belief, how you thinking that it should have been changed, or what is your way of forward?
For example, for instance, in our scenario in the Philippines is predominantly a Catholic country. So assisted reproduction, like the IVF or ICSI, somehow it's not incongruence there with their religious belief. But I think there's really ideal indications where we can offer this assisted reproduction for this set of patients. So it's not that we are dealing negatively with our religious belief, but this is for the best for our patients. We want to offer them we want to solve their infertility problems, and hopefully we can offer them the best service, the best care, so they can achieve this fatherhood and have their own biological children.
Okay, so Dr. Malan, then again the last question of this podcast: what is the your dream as far as the treatment modalities and the research of the andrology is considered? That my dream is to give the baby from the artificial womb, and 100% success in IVF. So what may be your dream as a andrology consultant?
Actually, same dream for every male patients who wish to be a father. Hopefully we can offer them the best care for them. Hopefully we can offer them the best outcome for them. But sometimes I always tell this to our patients, despite having us offering the best treatment options, giving them the best medications, and even offering them our our whole effort for in solving their infertility problem. But the reality is sometimes this will not result to our desired outcome, and that's a sad reality. So you should always tell our patients, even though I want you to be a father, by diagnosing you well, by treating you well, but sometimes it does not lead to our desired outcome. And that's I always tell them the sad reality. But hopefully in the future we can increase the chance of these patients who are suffering for infertility problem to have their own biological children and to be a father. So hopefully that we can solve all these problems in the future.
Dr. Marlon, it was really a what do you call as a pleasure of mine to listen to you, the great personality in the field of andrology. Dr. Marlon, from the Foxy side, we appreciate your effort in treating the male infertility across the globe and your knowledge and your expertise in the field of andrology. I myself, as a clinician in a IVF expert, I really take home certain messages from your side. That it's an one needs to change the belief. We needs to change the treatment modalities. We need to understand the problem, and we need to go. And what just now you talked about, I really that touched my mind is biological child that one should be getting it. So thank you, Dr. Marlon, for giving us a time, giving us a precious advice to what you have gathered throughout your career. And from the Foxy, we are really thankful to you and looking forward your presence in India early soon. Thank you very
Yeah.
much. And I'm really thankful to the audience who are logged in and going to watch this later. This is the message from the stalwarts like Dr. Marlon that everyone should dream at least for to have a parenthood with the biological child. And thank you, Dr. Marlon, for being a part of this podcast. Thank you very much.
Thank you so much again, Foxy, for this great opportunity and for this invitation. It was truly a wonderful evening. Thank you so much once again.
Thank you. Thanks a lot. Thank you.